Chapter 20. Respiratory Disorders. When you approach the patient with a respiratory disorder, the chief complaint often includes dyspnea, an abnormal awareness of one's breathing, and/or chest pain. A thorough history of the complaint is necessary to determine the cause of respiratory distress so appropriate treatment can be performed. The pulmonary tree is typipally divided into two broad categories, the upper airway and the lower airway. The upper airway is composed of the nasopharynx and oropharynx. The primary functions of the upper airway are to humidify and clean the air entering the lower respiratory tract. This reduces the chances of infection or foreign bodies entering the environment that is ideal for pathogen growth. In contrast to the lower airway, the upper airway is not sterile. It is suited for handling potential airborne infections. Mucus is secreted by specialized epithelial cells in the sinuses, nasopharynx, and oropharynx. This mucus helps trap airborne particles and pathogens, allowing expectoration. However, long-term tobacco abuse can overstimulate these cells, increasing mucus production and clogging the upper and lower airways. The right atrium receives blood low in oxygen and high in carbon dioxide from the superior and inferior vena cava and the coronary sinus. Blood flows from the right atrium through the tricuspid valve into the right ventricle. When the right ventricle contracts, the tricuspid valve closes. The right ventricle expels the blood through the pulmonic valve into the pulmonary trunk. The pulmonary trunk divides into right and left pulmonary artery, each of which carries blood to one lung. Blood flows through the pulmonary arteries to the lungs. Blood low in oxygen passes through the pulmonary capillaries. There, it comes in direct contact with the alveolar capillary membrane, where oxygen and carbon dioxide are exchanged. Blood then flows into the pulmonary veins. Carbon dioxide is exhaled as the left atrium receives oxygenated blood from the lungs by the four pulmonary veins. Blood flows from the left atrium through the mitral or bicuspid valve into the left ventricle. When the left ventricle contracts, the mitral valve closes. Blood leaves the left ventricle through the aortic valve to the aorta. Blood is distributed throughout the body through the aorta and its branches. Blood from the tissues of the head, neck, and upper extremities is emptied into the superior vena cava. Blood from the lower body is emptied into the inferior vena cava. The superior and inferior vena cava carry their contents into the right atrium, and the cycle begins over again. Respiration is a complex sequence of events that requires the participation of several components of the body. Inspiration begins with the signal passed from the brain to inhale. The diaphragm, the principal muscle of breathing, begins to contract. This contraction causes the thoracic cavity to increase in size. This increase in size creates a negative pressure in the chest, drawing air into the lungs to fill the void created by the negative pressure. Assistance may be added by the intercostal muscles, which are the muscles that connect the ribs in the rib cage. Intercostal muscles allow the ribs to move apart, further increasing the size of the chest and thus increasing negative pressure. During exhalation, the diaphragm and the accessory muscles of respiration relax, enabling the intrathoracic pressure to increase above the air pressure outside the body. This positive pressure forces air out of the lungs and into the environment. Intercostal muscles may assist by pulling the ribs together and increasing lung pressures. The abdominal muscles may contribute but function to increase pressure in the chest cavity and force air out. Normally, abdominal muscles rarely assist in inspiration. Begin with a physical examination. Perform an overall evaluation of the patient. The position of the patient can provide valuable clues to the cause of the respiratory distress. Patients with reactive airway disease often sit in a tripod position, as shown, to maximize airflow through the lower airways, whereas patients with pulmonary edema typically sit straight up with their feet dangling. Assess the patient's mental status. Hypoxia or hypercarbia can cause confusion, restlessness, irritability, lethargy, or coma. Indicators of respiratory compromise include the inability to complete sentences, the use of accessory muscles in the respiratory effort, and pursed lips on exhalation. Exaggerated chest movement with minimal air movement can and tracheal tugging suggest an upper airway obstruction. Make note of the color and condition of the patient's skin. Cyanosis, pallor, and diaphoresis are indicators of respiratory distress. Respiratory distress can lead to respiratory failure and eventually lead to respiratory arrest. All patients with dyspnea are at a risk for respiratory failure. Strictly defined, respiratory failure is the inadequacy of ventilation or oxygenation. Respiratory failure is often preceded by respiratory distress, in which the patient's work of breathing is increased in an attempt to compensate for hypoxia. Signs of impending respiratory failure include the following. Take note. Sleepy, intermittently combative or agitated, decreased muscle tone, decreased level of responsiveness or response to pain, inadequate respiratory rate, effort, or chest excursion, tachypnea with periods of bradypnea, slowing to bradypnea, agonal breathing. Even though respiratory failure arises from a wide variety of clinical conditions, management of its clear, aggressive airway control. In many cases, this involves endotracheal intubation and mechanical ventilation. Acute severe conditions such as chest trauma or severe aspiration can create an immediate need for airway control. Less dramatic but equally severe conditions such as status asthmaticus or COPD exacerbation can require aggressive airway management. Here we see the types of medications that the patients may be prescribed. A is going to be your rescue inhaler, B is going to be your nebulized treatments, and C is going to be your longer acting inhaler. Not only do these provide a clue as to their history of respiratory problems, but it also gives you an indication of where or how compliant they are with their medications. If you arrive on scene and they tell you that they just took an albuterol treatment, but you notice that half of the medication is still in the container of the nebulizer, you will understand that perhaps they're not being compliant completely with their medication regimen. Sometimes all you have to do is sit there and make sure that they take their medication as indicated. A bag mask device used without supplemental oxygen delivers only 21% oxygen, which is what is found in room air. A bag mask device used with supplemental oxygen set at a flow rate of 15 liters per minute delivers approximately 40 to 60% oxygen to the patient. Ideally, an oxygen reservoir should be attached to the bag mask device to deliver high concentration oxygen. The reservoir collects a volume of 100% oxygen equal to the capacity of the bag. After squeezing the bag, it re-expands, drawing in 100% oxygen from the reservoir into the bag. A bag mask device used with supplemental oxygen set at a flow rate of 15 liters per minute and an attached reservoir delivers approximately 90 to 100% oxygen to the patient. Continuous positive airway pressure, also known as CPAP, is the delivery of slight positive pressure airflow to prevent airway collapse, reduce the work of breathing, and improve alveolar ventilation. CPAP is considered a non-invasive technique using a snugly fitting mask that covers the patient's nose and mouth and is used for spontaneously breathing patients. Right ventricular failure may occur by itself, without left ventricular failure, in conditions such as pulmonary embolism or pulmonary hypertension. Pulmonary hypertension is a disorder in which the pressure of the pulmonary arteries is higher than normal. The right ventricle must work quite hard to overcome the increased resistance and eject blood. Over time, the right ventricle enlarges and eventually fails. Right-sided heart failure caused by pulmonary disease is called cor pulmonale. Cor pulmonale usually is a result of chronic obstructive pulmonary disease. Here we see another sign of COPD, which is going to be the clubbed finger, and this is due to lung injury. So there is going to be an increased entry of megakaryocytes into the systemic circulation. So typically under normal circumstances in a healthy individual, megakaryocytes that arise from the bone marrow are trapped within the pulmonary capillary bed and broken down before they enter the systemic circulation. So it's thought that in disorders like COPD, where there's right to left shunting, The megakaryocytes can bypass the breakdown within the pulmonary circulation and enter the system circulation. Then they are trapped within the capillary beds within the extremities, such as fingers, and they release growth factors. These growth factors promote properties and cause connective tissue to hypertrophy. Chronic bronchitis is an overproduction of mucus and enlargement of the cells in the lungs and airways that make mucus and cause congestion and blockage of the airways. Unlike emphysema, chronic bronchitis does not involve extensive damage to the alveoli. Therefore, it is defined in clinical terms rather than in terms of anatomic pathology. A productive cough for 3 months or longer, occurring for 2 or more consecutive years and without an identifiable cause, leads to the diagnosis of chronic bronchitis. This condition is caused by hypertrophy of the goblet cells and an increase in mucus production. It results in hypoventilation of the alveoli, dropping the oxygen level in the blood. CO2 is retained in the blood for the same reason. Acidosis develops as a result of the hypoventilation. The body responds by increasing cardiac output and increasing red blood cell production in an effort to get sufficient oxygen into the tissues. Now, emphysema, in contrast to bronchitis, does involve the alveoli. Long-term damage by either tobacco or inhaled agents causes alveolar destruction, alveolar coalescence, and destruction of the elastin fibers surrounding the alveoli. These pathologic changes are permanent and lead to a decrease in alveolar surface area, a decrease in elasticity of the alveoli, right to left shunting, and ventilation perfusion mismatch, an increase in the residual volume of the lung, a decrease in the expiratory reserve capacity, and a decrease in vital capacity of the lung. Combined, these factors cause chronic hypoxia and chronic hypercarbia. Blebs, or weakened areas of large alveoli, are often present on the surface of the lungs. These are vulnerable to spontaneous rupture and can lead to a possible pneumothorax. The increased work of breathing as a result of hypoxia affects the entire body. Polycythemia eventually occurs in all patients with COPD in an attempt to increase oxygen delivery to the cells. This progresses more slowly in the patient with emphysema than in the patient with chronic bronchitis. Muscle wasting occurs because of the increased caloric requirement of the work of breathing. The presence of muscle wasting gives the patient a thin and almost malnourished appearance. The increased residual volume results in physical changes of the thoracic cage as the anterior-posterior diameter becomes larger than the lateral diameter. This is commonly referred to as barrel chest. These patients often develop heart problems such as cor pulmonale and ventricular failure as complication. On physical examination, these patients exhibit dyspnea, cough, accessory muscle use, prolonged exhalation, and low oxygen levels. On auscultation of the chest, you can hear coarse rhonchi and wheezing. The patient may show signs of right ventricular failure, such as edema in the legs. Therapeutic interventions are going to include the supplementation of both oxygenation and ventilation. Initial steps should include providing oxygen sufficient to relieve symptoms of dyspnea or at least raise saturation to 90%. Therefore, treatment is directed at reducing bronchoconstriction and airway secretions. Nebulized beta agonists often are beneficial, including albuterol and ipratropium bromide. Asthma is associated with an inflammatory response that is expressed in the lower airways. Asthma is classified as a reactive airway disease. All reactive airway diseases lead to air trapping, CO2 retention, and the eventual development of respiratory acidosis. Unlike chronic reactive airway diseases, in which the patient is in a chronic state of respiratory acidosis, the patient with asthma maintains a normal acid-base balance early in the attack. If the attack is prolonged, respiratory acidosis occurs. The classic components of asthma are bronchospasm, bronchial edema, and excessive mucus production. Therapeutic interventions are going to include humidified oxygen, as it is preferred to avoid drying of respiratory secretions. CPAP, which is beneficial in reactive airway diseases and may prevent the need for advanced airway management and manual ventilations. As always, apply a pulse oximeter, capnography, and cardiac monitor. The use of inhaled medications such as albuterol can reverse the symptoms of asthma and reduce the need for mechanical ventilation. Albuterol is an inhaled beta-2 agonist acting on beta receptors to dilate airways, reducing the symptoms of wheezing. Ipratropium bromide is an anticholinergic medication that has slower acting bronchodilation effects than albuterol and also reduces airway secretions. Both medications are administered in nebulized form, which is a suspension of small particles of medication in air or oxygen. This method encourages delivery of the medication to the affected bronchioles, reducing the loss of the medication in the pharynx. In the setting of respiratory acidosis, the effectiveness of these medications is reduced. They work better in the setting of normal pH. When the left ventricle fails, blood backs up behind it, causing a chain reaction. Blood builds up in the lungs because the left ventricle is unable to eject all the blood within its walls. The left atrium swells with blood because it cannot empty the blood within its walls into the left ventricle. Stretching of the atrial muscle fibers may result in atrial dysrhythmias. The pulmonary veins cannot empty the blood from the pulmonary arteries into the left atrium because it already is full. Pressure within the pulmonary vessels increases, forcing fluid from the pulmonary capillaries across the alveolar walls into the alveoli of the lungs. This results in pulmonary edema. The congestion heard in the lungs is the reason heart failure often is called congestive heart failure. The buildup of fluid widens the gap between the alveoli capillary membrane, impairing the diffusion of oxygen and carbon dioxide. Spontaneous pneumothorax is a pneumothorax that occurs in the absence of trauma. A primary spontaneous pneumothorax occurs in patients without underlying lung disease. Young, thin, tall males are frequently affected by primary spontaneous pneumothorax, which presents with sudden dyspnea. These patients may also have tachypnea, tachycardia, and, depending on the degree of collapse of the lung, hypoxia. A secondary spontaneous pneumothorax occurs in patients with an underlying condition. Patients with emphysema are at risk for secondary spontaneous pneumothorax because of the destruction of the alveoli and formation of Blebs, which are large cavities that may rupture and cause pneumothorax. Mechanical ventilation may also cause pneumothorax. Another term used in this instance is barotrauma. Patients who have respiratory failure and require ventilatory assistance or intubation are at risk for barotrauma. Patients who require more pressure to ventilate, such as patients with asthma or airway blockage, are at a higher risk for barotrauma. Your therapeutic interventions involves the basics: providing oxygenation and ventilation, obtaining IV access and using a pulse oximetry, perhaps capnography, and EKG monitoring. The patient should be transported in a position of comfort because of spontaneous pneumothorax rarely causes a mediastinal shift. Thoracic decompression is seldom considered. However, if you have a paramedic, the paramedic should be alert to the possibility of the development of a tension pneumothorax.